Okay. So, good morning, everyone. So, first of all, I thank the organizers for giving me this opportunity. And regarding this topic, I think it's more relevant to the conference, which is Marina Pedicon. And I think it's more trending too. So, our Chennai right now reeling under floods. I think this topic is more trending. So, as you see, like our Chennai, our pediatric patients are more delicate, and unless you manage the fluid very meticulously, they're more prone for fluid overload or dehydration. So, as you see, as long as the stormwater drains are intact, which is like our kidneys, we are prone for fluid overload. So, as you see in summer, there will be more risks of dehydration. So we have to be very careful in fluid management. Okay. So this will be the overview of my topic. I'm going to cover a little bit about the physiology of the fluids, and I'm going to cover about the maintenance fluids, like how to fluid calculation and neonate infant transition and post-operative and raised ICT like that. A little bit about deficit therapy and like what are the things you need to monitor whenever you are giving fluids. I basically designed mainly for starters, and this is not for the experts. So I'm not going to go deep into the each and every condition. So moving over to the topic. So if you see about the total body water constitutes about the fetus and the neonatal life, it is very high, about 80 to 90% of the percentage of body weight. So and as the baby delivers and due to the postnatal diuresis, the total body water will reach the adult value around 1 year of age. Until puberty, it will be the same. The total body water will remain the same till puberty. And after puberty in females, the total body water content will be decreased compared to males. This is because of the more fat content in females, and whereas the males will have more muscle mass. So the total body water content in the adolescent or adult females will be slightly less. And this is the reason, like, we need to calculate the lean body weight for patients who are overweight or obese, because the fat has less water content. You need to calculate lean body weight whenever you're ordering fluids for a child who is overweight. Okay. And this total body water will be divided into two compartments, extracellular and intracellular compartment. So initially the extracellular compartment will be more in the fetal and neonatal life, and slowly, due to the increase in the cellular growth, the intracellular compartment will reach around 40% around 1 year of age. And the extracellular compartment, which constitutes the interstitial and the intravascular compartment, it will be around 20% of the total body weight. So how do you calculate the lean body weight is 50th percentile of the weight for height. That is a lean body weight. You need to follow that for a patient who is overweight. So this is the distribution of the fluids in each compartments. So like intracellular fluid will constitute 2/3 of the total body water, and extracellular is 1/3, out of which 1/4 of the extracellular is constituted by intravascular compartment. So whenever you transfuse in isotonic fluid, so it will stay more in the intravascular compartment, like about 25% or 250 cc per 1 liter. And whereas if you transfuse hypotonic fluid, only say 1/12 of the fluid will stay in the intravascular compartment. So what are the prerequisites you need to know while you order a fluid, maintenance fluid for any particular children? So first of all, you should know the indication for fluids. So unless the fluids are not indicated, you don't transfuse fluids. Just like that, don't give fluids for children. So as I said, so if the child is critically ill, so fluids can be detrimental to the child. It can cause fluid overload and can produce multiple problems. So you need to know first of all, you need to know the body weight of child. And if the child is overweight or obese, calculate the ideal body weight. And then you note all the losses of the particular patient. So I'll be telling what are the losses to be noted, so that you can do the deficit therapy and you can maintain the fluid balance. And before ordering fluid, you need to know a baseline about the electrolytes and sugars, so that you can decide what type of fluid you need to transfuse. And obviously, you need to have a knowledge about the fluids what you're going to transfuse. Unless you know like what are the composition of the fluids, it will be very difficult to plan your fluid management. So what are the sources of water loss? The major source of water loss is urine, which is about 60%, and Next to the insensible water loss, which is 35%, that is from the skin and the lungs, which we cannot quantify, that is called as insensible loss. And the stool loss for normal patient, it's around 5%, which generally don't take into account unless if the stool is more watery, which may lead on to dehydration. And having said this, like what are the conditions you may need more fluids? One is polyuria, where you have a urine output of more than 4 ml per kg per hour. And sometimes a child can lose more fluids even through salivation. So particularly in those children like cerebral palsy, or particularly we had a patient with a tracheostomy, he was drooling heavily, so which we took a few days to identify what is the reason for dehydration. And then hot and humid conditions, sometimes sweat can produce too much of water loss. And any patient who is on NG tube, like post-operative patient, and those on drains, you need to take all those losses into account so that you can maintain euvolemia. So the insensible loss calculation will be 400 ml per meter squared per day. And this is a formula for calculating the body weight. So it's better to use this meter squared so that you can have an exact measure of the insensible water loss. So going for how to calculate the maintenance fluid rate. So this will be given in all textbooks. You can remember the formula of 4:1. So for the first 10 kg, it is 4 ml per kg, then per hour, that is per hour. So then for the 11 to 12 kg, it's 40 ml plus 2 ml per kg per hour. Then more than 20 kg, it will be 1 ml per kg per hour. And so remember, there is a limit for the fluid which you have to transfuse per day. It will be around 100 to 120 ml per kg per hour. So don't try to exceed this fluid for any patient. And one point I would like to mention here is, so a neonate is from birth to 28 days of life. So like many times we have patients getting admitted to ward or ICU around 35 days like that. So many times we may tend to transfuse a newborn fluid protocol for that. So naturally, like whenever the baby crosses 28 days, we can follow this pediatric fluid protocol, this Holliday-Segar formula. Except in few conditions, like if the baby is extremely preterm, which has not crossed the corrected gestational age, has not crossed the term period after 28 days, and those conditions we can follow the neonatal protocol. Otherwise, you can go for the pediatric protocol whenever the baby crosses 28 days of life. So in what are the conditions you need to adjustments or like alter your maintenance water, like in few conditions there will be increase in water loss, like excess fever, sweating, and burns. You may know, like there will be excess loss through the skin, and the child is under warmer. And if the child is under incubator, the insensitive loss will be decreased. So we have to like restrict the fluids. And any patient who is having tachypnea, like particularly patients with bronchiolitis, the insensitive loss will be more. So for those patients, you may have to give extra fluids, or at least you can give full maintenance fluids. And if the child is on tracheostomy, again the insensitive loss will be more. So like you need to don't restrict fluids in those types of patients. And if the patient is under a ventilator, an intubated under ventilator, or also on HFNC, there you give a oxygen under humidified conditions, so the insensitive loss will be less. So in those conditions, you can decrease the fluids. And any GI losses like diarrhea, emesis, or any excess NG losses, you may have to go for excess fluids. And any excess urine losses like polyuria, you plan the fluids accordingly, go for extra fluids. And in other conditions like surgical drain or third space lossing, like in pancreatitis, so the patient will need more fluids, so calculate the fluids accordingly. So what are the conditions you can give full maintenance fluids? So many times patients like bronchiolitis and tachypnea, like I have seen patients restricting fluids. So that is generally not needed if the cardiac status is normal. So if the myocardial function is normal, it's a pure bronchiolitis. Otherwise, normal cardiac status, you need not restrict fluids. So in fact, as I said, they will be losing more fluids. So at least give full maintenance. Then you assess the hydration status, and then you can titrate the fluids. And one condition like I have seen recently is a cyanotic spell where the fluids are being restricted. So if the cyanotic spell is due to classical TOF physiology where there's decreased pulmonary blood flow, so excess fluids will help to increase the preload, thereby increasing the pulmonary blood flow. So in those conditions, you don't restrict the fluids. And in post-operative patient, if the sodium levels are normal, there is no evidence of SIADH, go for full maintenance fluids. And one more condition is raised ICT. So generally, some people tend to like restrict the fluids, but the risk is hypovolemia it will decrease the cerebral perfusion pressure. So you try to give normal maintenance fluids unless the child is on ventilator in case of raised ICT. So in what are the conditions, you need to reduce the maintenance fluids. So as I told, any patient on ventilator, HFNC, so give 3/4 maintenance. And if the patient has any cardiac conditions with myocardial dysfunction or cardiac failure, can restrict to 2/3 or 3/4 depending on the edema status. And as I told, if the patient has SIADs, this is very common in any like patient like admitted to ICU. So they will have low sodium levels with euvolemia. So in those conditions, you need to restrict fluids to avoid or correct the dilutional hyponatremia. So any patient with AKI with oliguria, restrict fluids, and any patient liver failure, so you restrict the fluids, and they may also have SIADs. So before you are ordering a maintenance fluid, so take the drug infusions into account. So for example, if you see this patient, and this is a post-operative patient, like appendicular abscess operated and had severe infection. So child is getting piperacillin, metronidazole, and pantoprazole infusions. So all these infusions will is coming around 20 ml per kg per hour. So the total requirement of this fluid is 75 ml, and we are giving only 50 ml. So just take all these infusions to account before you give any fluids. If you don't take this, the child is tend to develop fluid overload. Particularly if it is an infant or the weight is less, they're prone for fluid overload. So then that will lead on to the complications. So take drug infusions into account before you order for fluids. So before going to the composition of each and every IL fluid, so just a word about the osmolality and tonicity. So osmolality is just about the total number of osmoles in a volume of fluid. Just add the osmoles, you get the number, that is osmolality of fluid. So how much milliosmoles per kg. And the tonicity is, that is effective osmolality, and it includes only the effective osmoles that doesn't cross the membrane. So like sodium or chloride, that only is taken into account. Whereas if you take glucose, that will be metabolized and move out of the vascular compartment. So that will not be calculated for calculating tonicity. So tonicity is with respect to membrane. Osmolality is just total number of osmoles in a fluid. So having said this, I will move on to the composition of each and every IU fluids. So if you see, only the top 4 fluids are considered as isotonic. So normal saline, the plasmalite, which is being used like more in many setups, lactate or ringer lactate, and DNS. Only these 4 fluids are isotonic. And if you see, the DNS is hyperosmolar because of the dextrose content, which will add to more osmoles, but still it's isotonic. And if you see the sugar content, the normal saline has 154, and the chloride content in normal saline is more than the physiological range. So that is the reason the transfusion of normal saline is a few patients are tend to develop hyperchloremic acidosis. So that problem has been decreased by advancement of this fluid, plasmalite P, which has more physiological chloride levels. So that is the advantage of plasmalite. And this ringer lactate has a lesser sodium content compared to normal saline, and in fact the osmolality of ringer lactate is slightly less compared to our serum osmolality. So if you strictly speaking, RL is slightly hypotonic, but okay. So it is around 273, so it is considered as isotonic fluid, and DNS is isotonic. All the other fluids like half normal saline or our isolate P, which is 0.2 normal saline, are considered hypotonic, and you can see the isolate P has very little sodium, 23 milliequivalents. That is very little. So nowadays we are not at all using this isolate P, and this half DNS also is hypotonic. So this slide I want to say about this plasmalite P, which has additional this acetate and gluconate, which are the buffers in the fluid, so that the correction of metabolic acidosis is found to be better with our plasmalite P, and the incidence of hyperchloremic acidosis is less in plasmalite compared to normal saline. So having said this, what maintenance fluid to give for any patient, if the volume status is normal, so like that. So generally we order maintenance fluids for a patient who is who will be nil oral or who is critically ill, you cannot take orally like that. So for those patients, always isotonic fluid is advised. So the weight criteria has been removed now. So for all patients post neonate, you transfuse only isotonic fluid, which will be normal saline with added or DNS with added KCl. So normal saline as it doesn't have KCl, so you may have to add KCl additionally, like 10 to 20 milliequivalents per liter, which will be about 1 ml for every 100 ml. 1 ml of KCl for every 100 ml. Or you can use ringer lactate or plasmalite. So both these you can see has only little potassium. So ringer lactate or plasmalite has only 5 milliequivalents of potassium. So that is only very little amount. So just remember that. So for a patient who is normal, otherwise euvolemia, no SiADH, you transfuse isotonic fluid with full maintenance. Okay. So what you do for a patient raised ICP, as I told, like fluid restriction is no longer recommended. Go for full maintenance, and the fluid of choice is normal saline with KCl. And dextrose, you try to maintain around 100 to 150. So as long as the sugars are maintaining around 100 to 150, you continue with the normal saline. So if the sugar is falling below 100, you can add DNS. And if the sugar is again high, continue normal saline. And if it continues to be high, you may have to add insulin to correct the hyperglycemia, because dysglycemia, both hypo and hyper, are dangerous to the brain. Already it has occurred some insults. You have to prevent secondary brain injury. So try to maintain the sugars in a patient with raised ICP, and maintain euvolemia so that you maintain the cerebral perfusion pressure. Already the ICP is high. The CPP formula, MAP minus ICP. So unless you maintain the MAP in the upper limit, you are not going to maintain the CPP, and they are prone for ischemic injuries. So in post-operative conditions, you go for full maintenance, but remember, most of the post-operative patients are prone for SiADH. So check the sodium levels. If the sodium is normal, give full maintenance. Only isotonic fluid like normal saline, and take these losses into account: drain losses or NG losses. You have two separate lines. One line you put maintenance fluid. The other line you replace these NG or drain losses every 4 to 6 hours. So with what you will replace? So NG or an MS vomiting, you replace with normal saline with 10 ml KCl, or drain or any other chest tube losses, you replace with ringer lactate normal saline. So the normal saline is isotonic, and it will be like fine for most of the situations. So a word about the fluid in SAM, severe malnutrition. So this is a WHO recommendation. Like if a child has some or severe nutrition without shock, it's only oral or NG replacement with Resomol or half strength standard ORS solution with added potassium and glucose. The rate will be like 10 to 15 ml per kg per hour. You can continue for say 12 hours. So if the child has shock, so the replacement here is a kind of slow replacement with 15 ml per kg over 1 hour of oral with 5% dextrose, or half normal saline with 5% dextrose. If the child improves, you repeat the same for 1 hour. If there is no improvement, stop the bolus, start maintenance, and you treat it as septic shock, like with antibiotics and transfused blood. This fluid management has been under discussion, and many have don't agree with this. So I'm not going to the detail. I leave it to the expert. But only one point I will try to mention here is before you brand a child as SAM, just say you can see that any weight for length less the -3 Z score is considered as SAM. So you can see like this child about 75 centimeters length. A child above the -3 Z score is not SAM, whereas a child is less than -3 Z score is SAM. The difference between these 2 points is only 500 grams. So a child who is say having borderline weight or under moderate malnutrition, if the child becomes dehydrated, so in case of severe dehydration, the fluid loss will be around 8 to 10%. So that will be around 800 to 1000 ml. So a child with moderate malnutrition can sink into SAM due to dehydration. So just keep that in mind. So we have, like in our ICU, we are giving like liberal fluids for children with SAM, and many are tolerating. So if you are in a tertiary center where you can monitor the hydration status, you can do echoes. Like you need not go for restricted fluids in SAM. So like you can go for liberal fluids and monitor the fluid balance, and then you can decide. So what are the things you need to monitor while you transfuse fluid? So daily weight is very, very important, and go for a meticulous input-output chart where you document all the losses, like urine, NG, and drain losses. And clinical assessment is very important. So for example, if a child is diarrhea, you are giving fluids, but the ongoing loss will be more. So keep assessing the fluid status, look for dehydration, look for volume overload like periorbital puffiness or edema, and you can go look at the IVC to see the adequacy of the volume. So these things will help you to titrate the fluid. So any sick child, you don't order fluids like for a longer period of time, like 24 hours. So it is hourly or periodical assessment, and periodical change of the fluids has to be done. And check the sugars and electrolytes periodically, because many patients are sick, they are prone for dyselectrolytemia or dysglycemia. So check the electrolyte and sugars then and there so that you can alter the fluids. Going for the deficit therapy. So in case of diarrhea, dehydration, the fluid is normal saline or ringer lactate. I'm not going to do deep into the fluid calculation. It's given in all textbooks. So on dengue, it is isotonic, normal saline. Avoid hypotonic fluids like dextrose fluids like that. And go for early colloids, because any patient in shock in dengue, don't wait to add colloids. So after your initial 10 or 20 ml, you start adding colloids, and so that you can maintain intravascular volume. And one thing I noticed recently in this season is many children who are sick, they found to have urine output within the normal range. Generally, we titrate the fluids in dengue based on the urine output. Our target will be 0.5 to 0.8 ml or less than 1 ml per kg per hour. But many children had more than 1 ml per kg per hour, but still they had tachycardia, and still they had like altered sensorium, and like many child synced. So like if the child is sick, like don't only take urine output to titrate the fluids. So a word about plasma-like. So as I told, it has a lesser chloride content compared to normal saline. So the risk of hyperchloremic metabolic acidosis is less in plasma-like compared to normal saline. And because of these buffers in the plasma-like like acetate and gluconate, it is found to be the early correction of metabolic acidosis in patients with diarrhea like that. So that is the advantage of plasma-like, but it's a bit costly compared to normal saline. Like which hospitals can afford, maybe you can go for that if you experience these types of complications. So that's the 2 slides about colloids. So colloids are basically like they have more molecular weight, so that they'll stay more in the vascular compartment compared to crystalloids. That is the main difference between colloids. So it can be a natural or synthetic colloids. So like blood, plasma, or albumin are natural colloids. The osmolality is same compared to our isotonic crystalloid solutions, but since the molecular weight is more, so quite bigger compared to crystalloids, they'll stay in the vascular compartment for a longer time. So the synthetic colloids are starch, dextran, and Hemasil. So nowadays the starch is like being used commonly. So it has eta starch, and dextran 40 is another thing, and Hemasil are gelatin based colloids, which is derived from a non-veg source. So just keep that in mind. So so all these colloids are suspended in either normal saline like that. So the sodium or potassium content will be, chloride content will be similar compared to normal saline. So indications as of now, like the one definitive indication is dengue. So all the other conditions like sepsis, trauma, or ADD, or even pancreatitis are referred. And all this says like crystalloids are as good as colloids. There is not much difference between outcome in these conditions. And there are few selective conditions like where there is a child is overloaded or kind of edematous, you may go for colloids. I am not going to go deep into this. But dengue is one condition you can go for colloids. All the other conditions, it's decided on case-to-case basis. There is no general recommendation for this. So what are the concerns while giving colloids? So they're prone for anaphylactic reactions. Be ready to manage that. So like few colloids, they produce platelet dysfunction. So anticipate for coagulopathy. And since these are high molecular weight proteins or carbohydrates, they will be filtered in the glomerulus, and they're prone for renal failure. And they may produce fluid overload in already a patient with myocardial dysfunction. And colloids like dextran you interfere with cross matching. So when you use for trauma patients, you should be careful with that. So just to mention the importance of monitoring, just one case scenario. This 11-month-old child admitted to loose stools had hypotensive shock in the ear, given 20 ml per kg correction, and the shock was corrected and shifted to PICU and started DNS maintenance. In ICU, the child developed shock again, but whereas the mother gives only history of 1 or 2 loose stools. So actually, since the loose stools were not much, actually the shock was missed. Then after a senior registrar saw the child was found in shock, so again the bolus was repeated. So considering septic shock, the antibiotic was stepped up. So on further assessment, it was found that child had one sugar of 263, and so already child is getting normal saline. So we are monitoring. In between, child developed hypernatremia, so we changed the fluids to half normal saline. And after the sugar was continued to be high, it is around 330. So at that time we started insulin infusion, 0.05 units per kg per minute. So then the sugar slowly settled, and once it reached around 100, we stopped insulin, and then we are continuing normal saline. And then once it starts falling below 100, we started DNS. Then the child slowly recovered. So that's it. So like so this stresses the importance of monitoring in any child on fluids. So as a child is receiving fluid and due to because of the disease condition, they are prone for dyselectrolytemia or hyperglycemia. So unless you tackle this and titrate the fluids and treat all these conditions, the overall outcome is not going to be fine. So the take-home message will be like calculate the ideal body weight or lean body weight for overweight children before ordering fluids. Prescribe fluids only when absolutely indicated, and watch for signs of fluid overload or dehydration by clinical monitoring. Avoid hypertonic fluids. This isolate P or even half DNS is not being advised unless the child has hypernatremia, and monitoring is very, very important. So, thank you.
Thank you, Dr. Ekamarnath, for the excellent talk on fluid therapy in children. You have stressed on the physiology, the various fluids which are used, the isotonic fluids, colloids, and also the different conditions like ICP, post-op, SAM, and dengue. But also you stressed about one point in dengue. You said that nowadays you are getting patients with good urine output and still in shock. So how do we monitor such patients? How do you, what is your advice?
Yes, sir. It's a bit tough only. Even discussing with Tangavel, sir. The one thing is early colloids, early inotropes, and those patients with say encephalopathy. So recently, like IVIG is found to be useful. So after initially, actually, we have lost 2 or 3 patients. After that, with this type of fluid management and treatment, we have